Welcome to the Integrative Medicine Podcast. I'm Dr. Jordan Robertson. In this podcast, the best of both worlds of medicine come together, informing you of your healthcare options. This podcast is for the ultra-discerning, highly critical, and results-oriented health consumer, filtering out the good, the bad, and the real ugly when it comes to health information. As your host, my mission is to help you navigate the world of evidence-based integrative care and confidently make choices to help you live your best life. Enjoy! Hi, so we're going to start this episode. It's titled PMS and Why You Shouldn't Be Tested. And just a reminder, as we get into these more topic-based podcasts, that the purpose of these podcasts really is educational, right? So I am a huge advocate that listeners and patients be sure that they have a practitioner that they can work with on these issues. And the purpose of the podcast is not to diagnose you, it's not to treat you, but really it's to provide you some information so that you have the tools and the language and the ability to advocate for yourself to get treated by whoever your practitioner is. So with that in mind, we're going to talk a little bit about PMS, and this has been a huge topic for me over the last year. I've spent a lot of time researching PMS. I actually lectured for the Ontario Association of Naturopathic Doctors in the fall of 2017 on PMS and PMDD, and included in that was talking about how we can best assess women and some of the research difficulties that we have with this particular condition. So, keeping all of that in mind, so why do we even have difficulty studying PMS? Well, the problem is that we've defined PMS based on certain criteria that we know that needs to be present in order for the way that women feel to be honest to goodness from PMS. So, you need to have actually ovulated for your symptoms in that sort of luteal phase or that premenstrual week or week and a half or 2 weeks for our kind of unfortunate ladies. You need to actually have ovulated for that to be considered PMS symptoms. So keeping that in mind, I think you can probably start to come up with some examples of either maybe even of yourself where anovulatory cycles may still have some symptoms, or moments where we've maybe suppressed ovulation, such as with an oral contraceptive. And technically the symptoms that those women feel are not really PMS. So I don't mean to take that title away from you for all of my oral contraceptive women who also feel bloated and grouchy before their withdrawal bleed or from their placebo pills. But technically that doesn't qualify as PMS. But we don't always separate you women when we're studying you. And so even as we're building studies on PMS, we're creating them inherently flawed. So we will grab, say, a group of college women, age 21, and we'll study a whole group of them, and the study will fail to identify if any of those women are on an oral contraceptive or on some kind of hormone treatment that would suppress ovulation. And then we study them and try and decide whether or not some treatment or application or diet or whatnot that we do is actually fixing their PMS. But we haven't really done a good job in the first place of finding out if they have PMS. We also see this with some of the studies on herbs when we're looking at perimenopausal women. So there's a specific study that I'm thinking about that examines the use of St. John's wort and chaste tree. Both are really reasonable options for treating PMS. And the group of women that they studied were women who may or may not have had a period in the last sort of 14 to 16 months. So it was a subset of menopausal women. So they studied these herbs specifically for menopause. But if the women randomly had a period over the course of the study, they actually called them PMS women instead of menopausal women and tried to study them as a subgroup. When if you're not having a period, or if you're only having a period once out of a 14 to 16 month period of time, you probably aren't ovulating most of the time, right? And so we're likely not treating PMS in those women. We're probably treating their symptoms of perimenopause or menopause. So we have a problem as we're trying to define you. And this has trickled down to us having quite unsuccessful treatment in women in the community, because if we're not doing a good job of identifying our PMS women in the studies, we're really not doing a good job of assessing who has PMS or true PMS in our clinic. The other challenges that we have with studying PMS is that it has a massive placebo effect. And we've studied this again and again in various ways. I saw a study that was looking at IV therapy for PMDD, which is the more sort of psychiatric diagnosis of PMS. And I really got quite excited when I saw this as an IV practitioner. And it turned out that whether or not they injected the women with a Myers cocktail, which would be a sort of multi-nutrient formula with B vitamins, magnesium, etc., all things we would expect to maybe improve PMS. And the women got better whether we did that or whether we injected them without the ingredients. And so they used a Ringer's lactate, which is just basically a benign placebo IV bag. And so unfortunately, when we're studying you women, is that we actually need to do a good job of tracking women for a few months before we apply our treatment, because anything we do actually has a really profound impact on how women feel the following month. And that's for two reasons. One, there's a big placebo effect, but also we all remember our last cycle as being really, really crappy. So we don't have good, when we call it in science, retrospective data collection when it comes to assessing our last menstrual period. So every single woman remembers her last period or her last PMS experience as being worse than it truly was. And so if we ask women how their last period was, and she says it sucked, and then we track her going forward, and we know there's going to be a big placebo effect. Well, you can see the problem, right? We're going to overestimate the benefit of almost any treatment that we do for her. So this is creating a lot of problems for us in the research, because we can basically make anything look good, right? If you last month sucked and no matter what we do, you're going to feel better, that's certainly going to inflate the evidence for lots of things. And I think a lot of natural supplements have gotten away with some claims for improving PMS just based on those two things alone. The last challenge we have, which is where the title of today's podcast comes from, is that we really don't have any good lab assessments or even physical assessments to understand PMS. And so whether we measure your blood work, whether we measure salivary hormones or urine hormones, or doing a Dutch urine steroid hormone assessment, whether we measure your waist, when you're bloated or not bloated, none of these things will reliably help us understand your PMS. And even worse, none of them really help us decide how to treat you. And so I always tell patients when we're looking at lab assessments that if we're going to test you, the lab work really needs to tell us something we don't already know, or it needs to really profoundly change your treatment. And that's a really important concept, and we talked about that in the first episode of the podcast as well. So if I line up 100 women's lab work and I can't pick out who has PMS, or if I line up 100 sets of women's lab work and I can't tell how to treat any of them based off of it, then lab work shouldn't be the first thing we do. I would say perhaps with the exception of testing vitamin D, where treating adolescents and treating young women with vitamin D does seem to profoundly impact their experience of PMS. And I'm a big advocate of testing before treating, especially with some of the heroic dosing that we see in the literature. These will confirm ovulation, but they really don't tell us a whole heck of a lot more. So again, like I said, I know that may be mind-blowing. Sort of the purpose of or the advocates of salivary hormone testers are going to say, well, your saliva hormones are a better indicator of tissue levels of your hormone levels. Perhaps that's true, but knowing how much hormone is in the tissue, we don't have any good evidence on how to use that to direct your treatment. So even if we were going to use some hormone therapy, knowing what your salivary hormone levels are don't tell us what to do. Again, they probably are just confirming ovulation. And then the urine steroid hormone metabolites, which the advocates of that are looking at things from a detoxification perspective, to find out how your body is processing or dealing with steroid hormones. But at this moment, basically the best evidence that we have is that the urine progesterone metabolites are confirming ovulation, which we can actually do with a serum progesterone test, approximately at the mid-luteal phase, and knowing that the serum test is about the 10th of the cost of either of those other two tests, I am more of an advocate of using the blood levels of progesterone, and that is what we would use if you were going to use hormone therapy to treat any of your symptoms, whether it be PMS or not. You would actually use your blood levels to direct that treatment, and so that's why I'm not an advocate of those other two measures. Now, even testing serum hormones, like I said, so if I lined up 100 women's sets of lab work, I wouldn't be able to tell you who had PMS based on their lab work alone. Testing a mid-luteal progesterone will tell us if you've ovulated. However, if it does show up as a low level on that one day that we decide to test you on, that actually can overdiagnose anovulation quite often. So it's not very sensitive. So meaning that if we test you, say on day 21, which is usually as a practitioner our favorite day to send women for lab work, and your progesterone comes back and it's 4, we may diagnose it as an anovulatory cycle. So we usually like to see it, 20, 30, 40 progesterone in the mid-luteal phase. And so if it comes back as 4, we would raise the suspicion that perhaps you didn't ovulate. And I would say in the vast majority of cases, you did not ovulate. The other alternative there is that you have what we would call a luteal phase defect, where you did ovulate, but you couldn't keep your progesterone levels high for the entirety of your luteal phase, or of that second 2 weeks of your cycle. And that's really a topic for another day. But the reason I'm bringing that up is because a low progesterone on day 21, we actually think that overdiagnoses luteal phase defect about 15% of the time. Meaning that we don't have a good way of telling if that's just an anovulatory cycle, so you didn't ovulate, so you didn't make any progesterone, or if you did ovulate and you couldn't make enough progesterone, which would be a luteal phase defect. It's hard for us to use that lab work to differentiate between the two. Really, the best measure of luteal phase progesterone is to actually do 3 days in a row. So if we test you 3 days in a row, we're likely to capture sort of any variation in those 3 days. I describe the menstrual cycle as the 28-day circus to my patients, meaning that your hormones are essentially different every single day of the month. And so the day we decide to test you on may not be the best reflection of what's going on, and it certainly is not a reflection of how you feel. The other challenge we have with assessing PMS is that there are a lot of medical conditions that are exacerbated during the PMS window. So I'm going to say that again. So from a mental health perspective, there's a lot of mental health conditions that are exacerbated during the PMS window. So women who are depressed or kind of depressed are very depressed during PMS. Women who have a tendency for anxiety are very anxious during their PMS window. Women who have OCD may have a flare-up of their OCD during the PMS window. The challenge is if women are relatively functional and highly functional during the first half of their cycle, or if they've never really been assessed or well assessed during that follicular phase, we may ascribe their symptoms to being PMS when they have an underlying mental health issue. And so it's important that we actually track women going forward, and we track them during all the days of the month, because they may actually have an underlying mental health condition that is just worsened during PMS, or just brought out stronger or triggered further during PMS. But the treatment is different, and that's why it's important to differentiate. If you have depression all the time and severe depression during PMS, the treatment you should get is not the same as a woman who is completely fine and has no signs of mental unwellness or mental health issues during her follicular phase, and then has a flare-up of depression or anxiety during her PMS window. So it's very important. But interestingly, there's also a lot of physical conditions or other chronic diseases that are flared up during the PMS window as well. So women who have dysglycemia or who have diabetes or prediabetes are going to have a worsened blood sugar regulation during their PMS window. Women who have migraines or chronic headaches are going to have more headaches during their PMS window. Again, these are symptoms that may be ascribed to PMS if we don't do a good job of evaluating what an entire month, or really an entire 3-month period, looks like for women. So what are we actually going to do with you? So I use some of the validated questionnaires that are used in the studies to try and help women track their cycle-related symptoms for at least 2 or 3 months going forward. And that doesn't mean that we withhold treatment necessarily, but if we're confused about sort of the cyclical nature of women's symptoms, which is one of our other challenges, is that we often will report symptoms are being related to our cycle that aren't. Breast tenderness is the perfect example of this, is that often women retrospectively will note that their breast tenderness is related to their period, but when we track it going forward, there's a good chunk of breast tenderness that has nothing to do with a woman's cycle. So I use one of those validated questionnaires. I actually tend to use it's called the Daily Rating of Severity of Problems tracking sheet, which you can just download for free, the PDF of it off of just Google it. So it's a DRSP, Daily Rating of the Severity of Problems, which I wish we would rename. I use that tracking sheet, which is actually one of the more validated measures for assessing women with PMDD, which is like I said, more psychiatric version of PMS. But using that or some other way of assessing symptoms going forward and having women track it. A lot of the apps are great now for monitoring and tracking your cycle. So whether you track cervical mucus, which I'm a fan of for women to identify if their cycles are ovulatory. So that cervical mucus is that sort of egg white consistency cervical mucus that is present partway through the cycle, which it could be earlier than day 14, it could be later than day 14, but generally it's happening around mid-cycle. Some clinicians will suggest that women test their basal body temperature or wear there's actually new basal body temperature tracking devices, which again is probably more accurate. BBT isn't necessarily a reliable measure for ovulation, but we have evidence that it teaches women a lot about their cycle. We've looked at this mostly from a fertility or pregnancy perspective, and that we can help some women get pregnant by teaching them about their cycle. And some of the apps have room for you to do that. BBT, or basal body temperature, doesn't predict your PMS. But some of these apps now have smiley faces and sad faces and anxious faces, and you can sort of plug in what your physical symptoms are and what your mental symptoms are and track those over time so that you can see relationships between where your symptoms show up during when in your cycle. So there's actually an international society of PMS, and they've come up with sort of a standards of care for diagnosis. So the paper I'm pulling this from is called the Fourth Consensus of the International Society of Premenstrual Disorders, the ISPMD, and they've come up with standards for diagnosis and management of PMS. And if you're treating PMS in your clinic, I highly suggest you download the 4 documents that they have published on the diagnosis and management of PMS. But basically, to go through their standards, they are emphasizing the importance of gathering information from women and de-emphasizing the use of lab tests. So we want an accurate history, looking at the nature of your symptoms, how severe they are. So it's not enough just to say, yes, I'm bitchy, no, I'm not. Yes, I have breast tenderness, no, I'm not, or no, I don't. We want to track the severity of it and the timing of it with respect to your cycle, which again, that's why I'm a fan of those apps, because we can plug it in or track it based on which week of your cycle you're in. So they recommend that patients keep some kind of standardized symptom diary for at least 2 cycles. And what we mean by standardized symptom diary is that sort of writing in line by line how you felt on that day isn't that accurate. But if we can do check boxes or smiley faces or things that are kind of using a bit of a standardized scale, that can help us track your symptoms and be sure that we're being sort of the most accurate about it. So in order for you to qualify for the diagnosis of PMS, which I know every woman who's listening already has her hand up and saying, yes, I have PMS. But in order to qualify for a true diagnosis, and this is important, I can't emphasize it enough, it is important to get the right diagnosis because then you get the right treatment. Right? So don't put your hand up just yet. You need to track your symptoms. So basically, we need the diary to show that you have symptoms during the premenstrual phase and that they go away after you get your period. And this isn't including cramps, actually. So cramps are not part of PMS, and that's often enlightening for women. We consider cramps to be something completely different. And so knowing that you have cramps on day 2 or 3 or 4 of your period, that's not actually part of your PMS experience. PMS is your mental health symptoms and also the physical symptoms that should go away when you get your period. So we want to track the symptoms and we want to track them with respect to when they're happening in the cycle. And we should see them come during that luteal phase or that last week, especially coming into your period. And they should generally go away after you've had your period. The other big thing for us to track is your level of impairment. And what we mean by that is how impactful are your symptoms on your life. So there's lots of ways to track this. I generally get women to track their analgesic use. So talking a little bit about cramps there, which I know I just said are not part of PMS, but if you need to use analgesics for your headaches, if you need to use analgesics, meaning Advil or Tylenol for your breast pain, if you're changing your behavior because of your PMS, if you're missing work, if you're avoiding social activities, if it's influencing or interfering with your family life or with your relationships. These are important things to track. And so they've actually set a standard that your work should not be impaired by, or should only be impaired by less than 3 days. And if your family life is impaired by 5 days, then you're qualifying for this sort of diagnosis of PMS with pretty significant impairment. And the reason that we track this from the beginning is it helps us direct treatment and it helps us understand what kind of treatment we should offer women. So if women are missing a week of work and they're on the verge of getting a divorce every month, then perhaps we want to consider some treatment beyond, recommending a green smoothie and meditation, right? And so we want to know that level of impairment so that we can adequately match the intensity of your symptoms with the intensity of your treatment, but it also would help us understand your progress. And so if in month 1, you want to get a divorce and you have to miss work because of your migraines, and by month 3 you don't, right? Then that would be a significant improvement in your symptoms. And so it's important for us to track that. They also emphasize in the standards that we need to rule out ongoing psychiatric or mental health issues that have a premenstrual exacerbation. So like I already mentioned, we need to know that the follicular phase are good days and that it's the PMS where the central symptoms are coming. And it's not that we have bad days in the follicular phase and real bad days in the luteal phase. So it's important for that to be checked out, and also to be sure that there's no other underlying organic disease that is really just rearing its head during that premenstrual period every month, which is very common for chronic disease. Now, I know I mentioned earlier that lab work is not necessary. I will mention that one of these interdisciplinary consensus papers does suggest that there is some lab work done. They suggest TSH, which is your thyroid hormone, or thyroid stimulating hormone, your cortisol, FSH, estradiol in your follicular phase, and prolactin all be assessed. Now, none of these are to diagnose you with PMS. These are all to look at causes of other issues that will cause similar symptoms to PMS. And so that was their list of lab work. Like I said, I would probably throw vitamin D on there, mostly because that's going to help us direct your treatment. So I know a lot of you are listening are on an oral contraceptive, or you're not having ovulatory cycles, maybe you're perimenopausal, and you've got your hand up and you're saying, but I have PMS, right? Maybe you had PMS, during actual ovulatory cycles and you feel exactly the same way, or you've got symptoms, you've got the bloating, you've got the discomfort, the breast tenderness, and you're on an oral contraceptive. It's important to remember that those core PMS symptoms have to happen in ovulatory cycles, but there are some variants of PMS that don't qualify for true PMS, and that's where we get symptoms or hormonal symptoms even though we are not ovulating. So a lot of that is caused by synthetic progesterone use that's coming from an oral contraceptive. So I would say if you're not using an oral contraceptive for birth control, which it does do a good job at that, and you're getting PMS symptoms, you may want to reevaluate with your primary care practitioner or your naturopath just why you're taking it to be sure that you're getting the right care and the right treatment there. But a lot of the synthetic progesterones that are in those products, they do a great job at suppressing ovulation, but they also cause some PMS-like symptoms. And some women will continue to experience fluctuations in their hormones and PMS-like symptoms even though they don't have a period, so in that perimenopausal phase, or in anovulatory cycles. So you may have an anovulatory cycle for another reason. Perhaps you have PCOS. However, you still get symptoms of PMS. And like I said, that's just a variant of PMS. That's not true PMS. We likely would treat you the same. So like I said, it's not that we're measuring hormones and we're saying, oh, you didn't ovulate, your bloating doesn't matter. We probably treat you the same. It's just important for us to recognize that, because in some cases, we perhaps wouldn't treat you the same. And so it's important for us to look at that and to understand that a little better. If you've ever heard the term estrogen dominance, I think this is a good point in the podcast to sort of point that out, because, do I ever do lab work on women with PMS? Yes, occasionally we do lab work. And I would say with those cases, it's probably women who we've already tried to treat for a while, or who feel like they've tried everything for their PMS and they say, nope, you know what? I know there is something not right. What I always say to my patients when we start treating with PMS, I say, if we're still having this exact same conversation like 4 to 6 cycles from now, sure, we can do some lab work. We can assess your androgens, like your testosterone and DHT. We can assess your cortisol and your DHEA. We can check to make sure that you're having ovulatory symptoms. We could look at your metabolism and TSH and your insulin. So I'm not saying that lab work can't be useful, but what I'm saying is that it probably shouldn't be the first thing that we do, because most of the treatment that we would direct for PMS are not being directed by lab work. So that term estrogen dominance, I feel like that's a very naturopathic thing to say. We generally see, and this is the one time in the research that we can see a little bit of fluctuation in symptoms based on lab work, that women who don't have good progesterone production sometimes have more symptoms than women who do produce adequate progesterone. So a good example of that is probably breast tenderness. We see in women with breast tenderness that they may not produce as much progesterone as women who who don't have breast tenderness. The problem is that we can't really use that to direct treatment, because giving progesterone for PMS has never really shown that much support or that great of results when we look in the research. However, we do see, and this was actually originally studied in the 80s, we did see that perhaps that progesterone and estrogen ratio was related to how well women felt. But I would say by and large, when women have high levels levels of estrogen and low levels of progesterone, it's because they didn't ovulate, should be much more linked back to body weight, to visceral fat, to insulin sensitivity, than it should be just strictly looking at female sex hormones. But that may be an opportunity for us to understand a woman's entire case better if we start to look at things like her estrogen to progesterone ratio. The other test that I mentioned there that we would perhaps consider doing, again, that's really looking at things from a more total health perspective, because like I said, we can't actually distinguish who has PMS and who doesn't based on your peripheral hormones or based on your blood levels of hormones. What we think is happening in lots of cases is that it's actually just the sensitivity to those hormones or the sensitivity to the change in those hormones that's the problem, and not the crude number itself. So whether your estrogen is 350 or 500 may not matter. It's the fact that it changes rapidly, up to 500. That's where our women get symptomatic. We've looked at that sort of most specifically with PMDD, and we think that, again, that more psychiatric version of PMS is happening as a result of the fluctuation of those sex hormones and not the actual number itself. Cortisol is also another great example of a hormone that we really, really want to have correlate with PMS, but we've done like almost 15 observational trials now looking at cortisol levels with PMS, and we can't actually use that lab to predict how women feel, nor can we use it to figure out what to do with you. And so, although it's cool, and I do like testing adrenal function in patients if we think it's indicated or part of their case, but perceived stress can be just as impactful on PMS levels as an actual documented change in cortisol. And so it might be just as important for us to ask our patients whether or not they identify as their stress being part of their experience, rather than spending some money testing it. So this isn't all doom and gloom. So as we're going to close the podcast, I guess the big question is like, now what, right? So it is not all doom and gloom. Yes, there are no lab tests. But yes, there are things you can do. And yes, the treatments that we have for women experiencing PMS are great. And the ones that have been tested properly, right? So going back to the beginning, identifying women properly, having them track their symptoms for a few months, making sure that we're eliminating that placebo effect. There are some great treatment options for PMS that are totally worth discussing with your practitioner or naturopathic doctor or someone who's really experienced on the topic. And interestingly, I find with my patients that just tracking their symptoms help them feel better. It actually almost honors how they feel, and that we actually as women don't feel the same in every week of our cycle, and just tracking that and getting a little bit more in tune with that is important. So when in your cycle do you feel like a confident badass bitch? It's probably during your period or right after your period and during that follicular phase. When will giving yourself a 10-item task list make you feel overwhelmed and incapable? Probably during your luteal phase. Even if you don't identify your PMS as being a huge sort of substantial impact on your health, there's probably ebb and flow to your motivation, to your cognitive function, to your multitasking, that even just tracking can help us feel better. Sometimes during PMS, your daily task list should look like, have a shower, get dressed, go to work, and not think too hard about all of it, and leave sort of those big esoteric questions and world domination plans for your follicular phase. So track your symptoms for 2 to 3 months, and then I would suggest that you work with a practitioner who's really experienced in the topic, and don't sign up for any lab work in those first couple of months of treatment, because in theory, your treatment shouldn't be dictated by lab work. Working with a practitioner, I think, is important because it can help you rule out any PMS exacerbation of other underlying conditions. And so that's why that International Society of PMS suggests screening for thyroid, right? Because we want to be sure that there isn't something else going on that just is worse during your PMS week. So ruling out any other exacerbations like underlying depression or underlying metabolic issues, being treated, and I would say at that 4 to 6 months, if you're having that exact same conversation with your practitioner, then you might want to consider doing a little bit more lab testing to be sure that you're actually barking up the right tree. So I hope that was a helpful topic. This is a topic that's totally near and dear to my heart because I've spent a lot of time on it, and the research shows, and just in my experience, there are not many women who haven't been touched by PMS. And so understanding this topic and understanding how to support women best has actually had a really profound impact on my clinical practice just because of the vast number of women that are experiencing these symptoms. And you don't have to, right? We've got highly efficacious treatment options for women who experience PMS. The important part is to work with someone who A, knows what to look for and how to assess you, and B, knows how to treat you. And so make sure that you have this conversation with your naturopathic doctor or your primary healthcare practitioner the next time you see them, and talk about your treatment options for PMS, because you absolutely do not have to suffer. This concludes our episode of the Integrative Medicine Podcast. As I strive to bring you the tools and advice you need to make well-educated healthcare choices, I hope you listen along. Questions about the podcast or topic requests can be forwarded to our email at imedresearchhub@gmail.com. Remember to subscribe to receive updates on the latest episodes through iTunes, Stitcher, or Google Play.